This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled Endovascular-assisted microsurgical clipping of ophthalmic segment aneurysms.
This is a topic that hits home for anyone who has spent time in the subarachnoid space around the clinoid. Ophthalmic segment aneurysms, or OSAs, are notoriously tricky. We're talking about a very crowded piece of real estate. Alara, before we dive into the data, why don't you set the stage for why this specific study is so relevant to our clinical practice?
Absolutely, Dr. Aris. As we know, microsurgical clipping of OSAs typically requires effective proximal control of the parent internal carotid artery, the ICA. It's critical for a few reasons. It minimizes intraoperative blood loss if the aneurysm ruptures, it reduces aneurysmal turgor to make clip application easier, and it reduces the risk of distal embolization of any intraluminal thrombi.
Right, but proximal control is easier said than done in the paraclinoid region. Historically, we have a few options, but none are perfect. You can do a separate neck dissection to get to the cervical ICA, you can expose the petrous ICA in the middle fossa, or you can try for local intracranial control by dissecting beyond the distal dural ring.
And as the paper points out, those traditional methods are often associated with prolonged operative time and increased surgical morbidity. That's where this study comes in. The authors, led by Dr. Dalwati and colleagues, looked at temporary balloon occlusion, or TBO, as a minimally invasive alternative.
It's a hybrid approach, essentially. You're bringing the endovascular toolkit into the microsurgical suite. Let's look at the study design. This was a retrospective review from a single institution over a 10-year period, from 2014 to 2023.
Exactly. They included 34 patients with 35 OSAs, where TBO was the planned primary method for proximal control. What's interesting here is how they divided the groups. They compared patients who actually underwent balloon inflation, the plus TBO group, with those who had the catheter placed but didn't end up needing the balloon inflated, the minus TBO group.
That's a key distinction. It shows the just-in-case utility of the setup. Now, walk us through the technical success. Did they have any trouble getting the balloons in place?
Not at all. A temporary balloon guide catheter was successfully navigated to the cervical carotid in 100% of the cases. Out of those, TBO, actual inflation, was performed in 19 patients, covering 20 aneurysms.
Let's talk about the aneurysms themselves. What were the demographics and the morphology?
The sizes ranged from 2.8 millimeters up to 18 millimeters, with a mean of 6.7 millimeters. The average neck size was 4.2 millimeters. But here is the statistical significance. The plus TBO group, the ones who needed the balloon inflated, had a much higher proportion of wide-necked aneurysms. We're talking 55% in the plus TBO group versus only 26.7% in the minus TBO group.
That makes sense clinically. If you have a wide neck, you're often dealing with more complex anatomy and higher turgor, making that proximal control much more vital for safe clipping. What about the surgical approach? Did they mention the clinoid?
Yes, and this was another significant finding. Anterior clinodectomy was required much more frequently in the plus TBO group, 84.2% of the time, compared to 46.7% in the minus TBO group. The p-value there was 0.020. So it seems that the more complex the local dissection, like needing to take down the clinoid, the more likely the surgeon was to use the balloon for control.
It's almost like a safety blanket that allows you to be more aggressive with your bony work and dissection of the distal dural ring. Now, the million-dollar question for any neurosurgical technique: what were the outcomes and the complications?
The radiographic results were excellent. They achieved complete or near-complete occlusion, meaning a remnant of less than 2 millimeters, in every single case, 100%.
That's impressive for OSAs. And the safety profile?
There was only one complication with a permanent sequela, which represents a rate of 2.9%. When they looked at the functional outcomes at follow-up, the median modified Rankin scale, or MRS, was 0. Most importantly, there were no significant differences in complication rates or functional outcomes between the group that had the balloon inflated and the group that didn't.
So the act of inflating the balloon didn't add inherent risk compared to just having the catheter sitting there. That's a strong argument for its safety. The paper mentions that TBO is a minimally invasive alternative to open neck dissection. For the residents listening, let's break down the why behind that.
Well, the paper highlights that TBO obviates the need for a separate neck incision. That means no risk of injury to the cranial nerves in the neck, like the marginal mandibular or the hypoglossal. It also facilitates something very useful: real-time intraoperative angiography.
That's a huge point.
If you have the catheter already in the ICA for the balloon, you can shoot a run immediately after placing your clip to ensure patency of the parent vessel and the ophthalmic artery, and to confirm the aneurysm is gone.
Exactly. The authors suggest that this endovascular-assisted approach using newer generation balloon guide catheters really streamlines the workflow.
Let's look at the limitations. It was a retrospective study, and it's a single-center experience. But over 10 years, 35 aneurysms is a solid series for this specific technique. Did they find any specific challenges with the TBO itself?
They noted that navigating the catheter was successful in all cases, but they emphasized that it requires a coordinated team effort between the neurosurgical and endovascular teams, or, as is more common now, a dual-trained vascular neurosurgeon.
Right. It's the hybrid mentality. Now, Ilara, what would you say is the take-home message for a resident preparing for an ophthalmic segment aneurysm case tomorrow?
I think the take-home is that TBO is no longer just a rescue technique, it's a proactive strategy. The study proves it's safe and effective. If you're looking at a wide-necked OSA or a case where you know you'll need an extensive anterior clinodectomy, having TBO ready and using it provides proximal control without the morbidity of a neck dissection.
Well said. It really simplifies the surgical field. You don't have a second incision site to worry about, and you have that immediate feedback with intraoperative imaging. I was particularly struck by the fact that even for the wide-necked aneurysms, which we know are the high-risk ones, the outcomes remain consistent with the smaller, narrower ones when TBO was used.
It levels the playing field in a way. The authors concluded that TBO is particularly advantageous for those white neck cases.
It's a great example of how technology from the endovascular side is actually enhancing our ability to perform open microsurgery safely. It's not one or the other anymore. It's about using the best tools from both worlds.
Agreed. And with a complication rate of only 2.9% in a complex paraclinoid population, it's a very compelling case for adopting this as a standard of care in high-volume centers.
For our listeners who want to see the specific data tables, especially the breakdown of the fluoroscopy times and the catheter characteristics mentioned in the methods, I highly recommend pulling up the full text in Acta Neurochirurgica.
The study is a quick but dense read, and it includes some great supplementary information on the procedural specifics.
This has been a great deep dive into the evolution of OSA management. Thank you, Dr. Ilara, for bringing this paper to the hub.
My pleasure, Dr. Aris.
And thank you to our listeners. Stay tuned for our next episode where we continue to bridge the gap between the latest research and your clinical practice. Until next time.
Goodbye, everyone.